Today I'm going to learn about this session will be taken by Dr. Hashmath Farhana, who is a palliative physician. She did her certificate course in pain and palliative medicine from Institute of Palliative Medicine, Calicut, and also she did her fellowship in palliative medicine from the same institution, and she did her fellowship in palliative care from St. Christopher Hospice, UK. She is a well-versed person in this field. Welcome and over to you.
Thank you, Sister Shiva, for introducing me. Good afternoon, everyone. The topic for today is delirium, and I'll be talking to you all regarding the same. I think we can start with the presentation for today. Just give me a moment. I'll just share my PPT. So we will be starting with the presentation for today. So moving into the topic, so first we should know what is the definition for delirium. So delirium is a transient organic brain syndrome. So what do you mean by the word transient? Because transient is a word which symbolizes that the symptom is lasting only for a short time, which comes on and off, and also it is impermanent. And when you say it's organic, it is not something which is purely psychiatric. So it is a delirium is a transient organic brain syndrome which has an acute onset of few days to hours. That is how patients present to us with delirium. And there is an acute onset of global cerebral dysfunction. So when you say global cerebral dysfunction, it means that the total cerebrum gets affected and there is a disturbance in the psychomotor behavior. So when you say psychomotor, what do you understand? It will create some psychological disturbances as well as motor disturbances in terms of movements. So that is how delirium presents to us. So delirium is associated with a medical condition. It can be associated with the medical condition. So I will be talking about the causes later. It can be associated with intoxication as well as substance withdrawal. So that is how caregivers report to us like the patient has been having so-and-so symptoms for long. Patient has altered behavior. He talks incoherently and confused and all that. So just to move forward, I would just start with this clinical scenario. I want you all to read this scenario. So it is a 70-year-old gentleman with paraplegia. He is brought to the casualty where you're working with complaints of altered behavior, which was noticed by the family members for the past 3 days. So it is something which is acute. And he talks incoherently and appears confused. His oral intake for the past 1 week is low. He is receiving analgesics for pain management. He is on indwelling catheter, and family members report that he has not moved bowels for the past 5 days. So I just want you all to keep this scenario in mind. We will be taking this entire discussion at the end, but just keep this scenario in mind and we will move forward. If you want, you can just click a screenshot, like take a picture of this and keep it in your mobile, just for you to at the end discuss and all that things. So the diagnostic and statistical manual, DSM-5 criteria says that there are some criteria which has to be there to say that this patient has got delirium. So there should be a disturbance in attention as well as awareness. And it should be an abrupt onset. As I said, it should be from hours to days with fluctuation in the severity of symptoms. Whenever we see a patient with delirium in our inpatient unit or during our home care, there is a lot of fluctuation with the severity of symptoms that we see. For example, if I take a duty in the morning, I see a patient, I understand that he is little delirious, and then the same time, I mean, on the same day, if some other doctor goes and sees at night, the picture might be totally different. So it has an abrupt onset with periodic fluctuations. There is a change in cognition. When we say cognition, there is a disturbance in orientation, perception, interpretation, as well as memory. Okay, so these criteria have to be there to say that so and so patient has got delirium. It is not better explained in terms of other neurocognitive disorders. For example, there are many other neurocognitive disorders like motor neuron disorder or something like Parkinsonism, but these patients might not present with what you're going to see in a patient with delirium. So the symptoms vary. And the evidence of a medical condition should be judged by etiology relatively. Like, you have to think about the various causes for delirium and then you have to determine that which cause has led to this problem. So mostly delirium is something which is very much reversible. So these are some of the facts about delirium. It affects 28% to 83% of the population. It is reversible in more than 50% of the patients. It affects the quality of life a lot. Obviously, when you see a patient with delirium, most of the times we admit the patient and we manage him or her at our inpatient unit. It is because it will lead to a lot of issues. Like, when the patient is in delirium, he or she might not be able to take food properly. The caregivers might feel it very much challenged and they will be very much anxious, thinking, what is happening to my father? What is happening to my mother? So obviously, it increases the morbidity. It increases the morbidity as well as the hospital stay and causes distress to the family, especially to the primary caregivers as well as the whole family. And it poses a lot of challenges with the diagnosis as well as managing. That is when most of the doctors, when we are seeing patients with delirium, many times we will not be able to diagnose it properly. Even the doctors as well as the caring team find it very challenging to diagnose and treat it because many times it goes misdiagnosed. So these are some of the important facts about delirium. So the burden of delirium is there in about 30% of hospitalized patients. So when a patient is hospitalized, there are 30% chances of being in a delirious state. And also it is about 85% of the patients in end of life. That is what we term as terminal delirium. Most of the times when the patients get admitted to our inpatient unit, when they are terminally ill, more than 85% of the patients will present with terminal delirium. So, okay, so delirium has occurred. So, what does it cause? So, it is going to lead to a functional decline, which results in impairment of the cognition as well as the mobility of the patient. You can imagine when a patient is very delirious, restless, he will not be able to move properly. He might be restrained to the hospital, to the home, like, they might tie him. And all these things happen because family members wouldn't be able to handle him. So this can also lead to fall, especially in elderly age. Think about it. When a patient is 85 years old with delirium and the family is not able to take care of him properly, he might walk to the toilet, he might fall down, it will lead to fractures. So it will affect the quality of life a lot. And also there will be incontinence. Most of the time, the patients will have incontinence of bowel as well as bladder and failure to maintain adequate hydration and nutrition. Since the patient is very, delirious, we might not be able to give proper food for him. He might avoid taking food. There will not be proper hydration. There will be physical and chemical restraints. And also it will, as I said, it will lead to a prolonged hospital stay. About the emotional burden. As palliative care professionals, as palliative care nurses, what do we actually do? We assess a person in total. We assess the physical, the emotional, the social, as well as the spiritual component of the patient as well as the family. Think about the emotional burden the family will have while taking care of this patient. So it is very important that you need to communicate in a proper way to the patient. Maybe the patient, if he is delirious, he might not understand what you're going to tell him, but you need to talk to the family very clearly, stating that so and so has happened and the patient is delirious. This is how it's going to be. And we are trying to manage him and bring him back to normal. So that is how you need to build up a proper rapport, as well as the good communication needs to happen along with the caring team getting involved, especially the nurses. As nurses, I think you have a lot of work to do because you will be the people who will be meeting the patient as well as the family members first, who has a very good rapport with the family members, who will be able to talk to them and convince them and make them understand what is actually happening. So even if this is mistaken or if it is not properly managed, that could also occur, especially in terms of hyperactive delirium. When a person is very hyperactive, then obviously people might think, okay, he's very hyperactive, he's delirious and all that. But when he is hyperactive, many times people might think nothing is happening to him. So they might miss delirium when it is a hyperactive type of delirium. So these things are there, and we need to keep this in mind while we are managing each and every patient who is delirious. So always there is a confusion between delirium as well as dementia, because dementia is something which is different, but delirium is totally different. Delirium has an abrupt onset. As I said, it happens within few hours to days, whereas dementia is insidious. It starts slowly and then starts to progress. When there is dementia, especially a kind of Alzheimer's, if the patient is having an Alzheimer's type of dementia, or if it is a vascular dementia, whatever it is, the presentation is going to be totally different. It is going to be insidious and it's going to be slowly progressive. And here in delirium, there is an altered level of consciousness. But in terms of dementia, the consciousness level is actually very, very intact. But in case of delirium, you can also see that the sleep-wake cycle is very much affected. Most of the patients with delirium will not have a proper sleep. They might not be able to sleep well because they are very delirious. And we need to manage the patient by giving some antipsychotics along with some benzodiazepines. So these many things are there. But in case of dementia, there is a very minimal variation in terms of sleep. It doesn't affect the sleep-wake cycle a lot. And also, delirium is reversible. As I said, in more than 50% of the cases, delirium is very much reversible. But in case of dementia, practical considerations, I would say that it's irreversible. Few kinds or types of dementia are a little bit reversible, but for practical terms, we take it as dementia is irreversible. And in case of terminal delirium, mostly it might not be reversible because the patient will be in end of life. And the primary goal of our caring team is going to be you are going to manage the patient so well, you're going to keep him or her very comfortable. So we are not concerned about the causes for delirium a lot. Sometimes even that can be multifactorial. But most of the terminal deliriums are not reversible. Other kinds of delirium, which is due to metabolic disturbances, whatever it is more than 50% reversible. So as I said, there are different types of delirium. One thing is hyperactive delirium, where the patient is very, very much agitated. The second one is the hypoactive delirium, where the person remains so silent. The person remains very silent. He doesn't talk much, seems to be like in depression, but you might think that it is because the person is not speaking, that's all. But actually, he might have a delirium picture at the back. And also that can be mixed, the person can have a hyperactive as well as a hypoactive delirium. Both can, come together. And also, as I said, refractory or terminal delirium, which happens in end of life. So these are the 4 types of delirium. I hope it's clear for all of you. Everyone is able to hear me clearly, right? You can unmute and just say,
Yes, yes.
yes. Okay, we'll move forward. So as I said, the hallmark of delirium is attention deficit. The person will not be attentive. See, now you are all attending to this session. You all are very attentive to whatever I'm speaking, I suppose. So the main hallmark of delirium is going to be attention deficit. The person and the patient might not be able to answer a few questions that you're going to ask, might not be attentive, might not be oriented to the time, place, and person. For example, to ask him or her, where are you right now? And he might say he's at home, he might be in a hospital setting. Or you can ask him, like, what is the time of the day? And he might say it is 10 p.m., but obviously it is going to be somewhere around 9 a.m. in the morning. So that is how delirium presents to us. So the hallmark of delirium is attention deficit. So these are some of the very common clinical features for a patient with delirium. There can be poor attention. As I said, the hallmark is attention deficit, and there will be impairment of the short-term memory. Like, for example, you ask him, what did you have in the morning for breakfast? You ask it at around 11 a.m. and he might not remember. Or he might say some other, he might say something which is irrelevant. So that is an impairment of short-term memory. There is going to be disorientation as well as misinterpretation. There's going to be hallucination. For example, people might say, I can see some snake down. I'm in my bed, but I can see some snake down. I can see some spiders which are flying. And all these things happen in a person with delirium. And also there can be delusions, rambling, incoherent speech. There is no coherence with whatever they speak, like when you speak to them, they might say, they say few words, and after some time they become a little agitated, restless, and again they say something else. So it is totally incoherent speech. And in terms of hyperactive delirium, the person will be very agitated. Sometimes even the environment will be very noisy because he's making those noises, has an aggressive behavior. But in terms of hypoactive delirium, the patient is going to be very lethargic and sluggish. That is when we don't diagnose it as delirium, because we often think delirium is hyperactive, but most of the times the patients that we see, even in our IP as well as in the OPD, most of the time they present with hypoactive delirium. So it is very important that we understand the various causes for delirium. So these are some of the drugs, there are certain causes for delirium. First, I would like to go with the mnemonic delirium. As you see, DLIRIUM. So D for drugs. So there are certain drugs which will have an effect on the agitation. There will be an effect on agitation. For example, dopamine. Neurotransmitter, it works through, like when you give haloperidol, it works through dopamine, and obviously the agitation comes down, and that is why we use haloperidol as the first line of management for delirium. And there are several other drugs, which can increase delirium, like rivastigmine and donepezil. And when haloperidol is not indicated, for example, if the person presents with EPS, that is extrapyramidal symptoms, then obviously we might choose some other drugs like quetiapine, olanzapine, or risperidone. And these are some of the drugs like dexamethasone, the most common drugs that we use in a palliative care setting, like dexamethasone, morphine. All these can cause delirium. So it is very, very essential that we need to understand. And you need to keep in mind that, for example, you are seeing a patient in the morning, and then the doctor comes and starts morphine. The patient was on tramadol in the morning and then assessed the pain, and then he was in pain. They just changed it from tramadol to morphine. You have given morphine at around 10 a.m. today morning, and then at 11 a.m. you notice that the patient is delirious. Then you obviously have to note it down that after taking this medication, the behavior of the patient is little bit altered. You are noticing that he or she is in delirium, and then you have to report it to your team. So these are some of the drugs, as well as withdrawal states. When a person stops alcohol, obviously it's something which is very good. But all of a sudden, if he stops and then he goes into a withdrawal state, it can present with delirium. That is, I think most of you would have seen where delirium tremens, you would have heard, right? When a person is very much alcoholic, he stops alcohol for 1 or 2 days, and obviously when there is a withdrawal period, he comes to our OPD being very, very delirious. I have seen during my undergraduate period and all, when the patient was standing on top of the bed and he was dancing the whole night at around 3 a.m. So these patients, withdrawal states also precipitate delirium. And low oxygen states or insults, especially when there is an involvement of the brain, CNS involvement in terms of EMI or stroke. In terms of stroke, whenever a person presents with stroke, can present with delirium also. And when there is a pulmonary embolus or some vascular events that are happening, and also hypertension, when there is a very high BP, and then patients can present with delirium. It's because which is a secondary phenomenon when there is a metabolic abnormalities, like in terms of hypokalemia, hyponatremia, there is some disturbance which is happening, and then the brain processes it and gives it, and the patient comes with delirium. And also infection. Infection, for example, in terms of encephalitis or sepsis, whatever it is, the person may present to your OPD with delirium. And the most common things as palliative care professionals, which we need to be very clear about, is pain. Pain when it is not properly addressed, or if the person is having severe pain, obviously he or she can present with delirium. We have seen many patients who come with 10 by 10 pain score, be very, very delirious, and after giving a morphine trial, completely settles and is totally fine. So you need to keep in mind that pain also causes delirium. Severe pain can lead to delirium. And also infections, retention of urine. Obviously, when there is a urinary retention, as nurses, you should be very clear. Like, if the patient comes to your OPD, is delirious, you should see and ask the caregivers if he is passing urine adequately every day. Or if he is on catheter, you should check the output. And you can palpate for the bladder. You can see if the bladder is very full. Obviously, what you can do is you can drain the urine and he becomes totally fine. So, urinary retention is something which leads to delirium. And also constipation. When it is a long constipation, for example, if the patient has been constipated for 3 days, 4 days, for a week, for 2 weeks, they can present to your OPD with delirium. And post-ictal states. Post-ictal is when a seizure episode has happened, and after a few moments, the seizure ceases, and then after a few minutes, the patient will go into post-ictal state. So post-ictal states can also lead to delirium and metabolic abnormalities, like as I said, hypercalcemia. Most of the patients that we see in palliative care settings come with cancer. Hypercalcemia is very, very common. So hypercalcemia can lead to delirium, and hypokalemia, and also can be hyponatremia. All these, metabolic abnormalities can lead to delirium. As I said, CNS causes that can be primary, which are confined to the brain alone, and also can be secondary, like in terms of whatever I said, metabolic abnormalities, which is a secondary phenomenon which is happening elsewhere in the body, and it is creating delirium for the person. Then the person is not able to see clearly. When the person has some vision problems, when he has a diplopia or something like, blurred vision, all these things can also lead to delirium. So these are some of the important causes that you need to keep in mind while seeing a patient with delirium. So everybody is at risk of delirium. It's not that I can't get it or Sister Shiva can't get it. It's like everybody can get delirium, but we will see about the individual risk factors. See, it is very low in young age when there is no dementia, when there is no chronic disease, because obviously you are not going to see more patients with delirium. But it's high when a person ages, when they are frail, when there is dementia, when there is chronic disease, obviously the risk of delirium increases. And also the triggering factors, it is high when there is a sepsis, when there is a high risk of surgical procedure, when there is a nerve toxicity. All these things increases the risk of delirium. So the triggering factors for delirium would be the change in environment. This is very, very, very important, because many times you would see some patient, like for example, when a person is in the ICU, he was at home for a few days, he becomes very sick, has been shifted to the ICU. Just imagine how an ICU setup is like when you see everybody wears same clothes, everybody has a mask now because it's COVID, everybody has an apron, and everybody wears something in blue. There is no clock for the patient to see the time. He's not oriented. Obviously, and also the sounds, especially from the machines like ventilator, like whatever machines that we use in ICU setting, sounds can actually trigger delirium. So all these things are an important hallmark, for triggering delirium and the general deterioration that is happening for the patient. Like for example, as I said, the patient is becoming very frail, and that is a general deterioration to the patient. He's going into end of life. He or she might not have any other diagnosis except frailty. Might be 92-year-old women who presents with delirium in her end of life. So general deterioration is an important thing, and uncontrolled symptoms, as I said, like pain which is very much uncontrolled, is a triggering factor and is a positive factor for delirium. And primary and secondary brain tumors. Since it is delirium, most of the times we often think that only CNS causes are the prime reason for delirium, but it is not so. CNS is one of the cause. Central nervous system is one of the cause for delirium, but we have many other causes. So do keep that in mind whenever we are assessing a patient with delirium. As I said, biochemical disturbances, that is the electrolyte imbalances, drug-induced can be steroids, can be narcotics, can be morphine, tramadol, whatever it is, and withdrawal states. Okay, sorry. So withdrawal states, especially with alcohol, organ impairment, sleep deprivation, when there is no proper sleep, that can also lead to delirium. Post surgery, a person can have delirium and trauma. So how are you going to assess this patient? So before that, if you have any questions or you can't follow me, if you have any doubts, I think we can spend a minute for that. Is it okay for each and every one of you? I want you to just put it out in the chat box or just unmute and say if you have anything. Is it clear? The voice is clear?
Anupama, is there any specific point to little bit of breaking?
Does everybody has this issue like my voice is breaking in between?
No. No.
I think any one of you can unmute and just say how, if you are able to hear it clearly or not, so that we can proceed further. Okay. Okay, so we can proceed. So as a nurse, how are you going to assess a patient with delirium? So it happens at the bedside. If you're going to see a patient in home care, if you're going to see a patient in your casualty or in your IP, it has to be bedside and daily at regular intervals. When a person presents to you with delirium, at least 2 hours once or 1 hour once, you just go and see whether the patient is okay, comfortable, and all that. Okay, so daily at regular intervals, you need to go and see the patient. And also, when you give the handover to someone who is going to take the duty next, you need to be very specific, very clear. Tell that this is how the patient presented, so that the next person who is coming, who doesn't know anything about the patient, will understand. This is how we'll have an imaginary clinical picture of how this patient came. So she might be able to compare and see whether the person is okay at night or whatever it is. So nocturnal presentations, most commonly the nocturnal presentations, even in our IP units, are missed because we need to check whether the person is comfortable and all that. Otherwise, it goes missed. And also, you will take the proper history from caregivers. Whenever you're taking a history, I know you all might be very familiar and very used to taking a history of how you manage a patient when they come to your inpatient or your OP. But you need to be very clear about how many episodes they had, when did it start, how did it start, what are the medications they are taking. That is how we assess, right? When a person comes to our OP, you need to ask the entire list of medications he was taking. Might be few medications he would have stopped previously, new medications that would have been started the previous days. So all these things are very, very important while you are dealing with a case of delirium. So there are many other assessment tools to ascertain the cognitive disturbances. One thing which is very commonly used is the mini mental status examination, which gives emphasis on orientation, registration, attention and calculation, recall, as well as language and praxis. So orientation is like, when they come to your OP or to your IP, you can just speak to the patient, ask, where are you? What is the time now? You have to see whether he is oriented to time, place, and person. And you can ask his name and if the wife is next, you can ask what's her name, who is she, and all this for orientation. And then for registration, what you can do is you can select three different things. Like, for example, you can say ball, cat, and apple. And you can ask them to repeat it after you, like after a few minutes. And sometimes they would be able to say correctly, but when a person is very delirious, he might not be able to say it in a proper way, like how you have told it. And recall is something which you do it at the end. Like at the end, you again ask him, I told you three things when you came here. And can you recall that and tell it? Mostly, if the patient is delirious, might not be able to say that. For attention and calculation, you can say, for example, I want you to subtract, 5 from 100. Like, I want you to say the multiples of 100, multiples of 5, something like that. You can say 100, 95, 90. I just want you to minus 5 and then say 5 numbers. Something like that you can do. Understand how he is attentive and how he is able to calculate. And when you are assessing with all these tools, the total score is 30. And when it is less than 24, that will be a severe cognitive impairment. It says that the person is very delirious and has a severe cognitive impairment. You can just Google this mini mental status examination. It's a chart. You can see that. You will be able to understand it pretty well, and you can employ this in your clinical setting, and you can score and then just understand, the patient came with a severe cognitive impairment. Right now, he is improving. All these things we will be able to do if you follow a mini mental status examination. And there are also other diagnostic tools. If you search, there are so many diagnostic tools, but I wanted to go with MMSC because it is easier and can be incorporated into any setting. And there are other diagnostic tools like confusion assessment method, memorial delirium assessment scale, and also severity assessment. You can do the severity rating scale, like how you do for pain. So that is also there. But MMSC is something which is really good, and you can do it and try it at your city. So investigations. So when you go over the investigations, first you need to assess the need, and then go with the proper investigation. Might be if the person is going to die, the person is going to die in a few days. You see that the person is, a cancer patient who is in terminal delirium, is in end of life care. There is no need to go for several other investigations to find out the actual cause for delirium. You can look into certain factors like whether he has pain, whether he has a constipation, whether he has a urinary retention. These are some things which are very, very common when a patient goes into end of life. And if you correct that, obviously he becomes little better. That is one. And you need to investigate to support the clinical diagnosis and management. Unnecessarily, don't go for many other investigations, and also avoid investigations in terminal stages. That is very important. Clinical test. As a nurse, I think you can go for, a complete blood count, electrolytes, to check whether he has any metabolic disturbances. You can go for a renal function test. Hypoglycemia also causes delirium. So you can just check the GRPS. You will be able to know whether there was a hypoglycemic episode that precipitated delirium, and also urine routine examination to see whether he has an infection and all that. So CPU brain is something which is required in consultation with the primary consultant. As I said, we don't need to do all investigations, but you need to be very specific. Think about the causes that can occur in this patient and then decide on your investigation. Don't go randomly into so many other investigations, creating a burden for the patient as well as the family. Okay. So in the principles of management, it is very important that you give more and more, attention to general measures. Then you have to go with the pharmacological measures. I'll be talking about the general measures and pharmacological measures, especially based on the etiology. You have to correct the correctables first. Whatever is correctable, if you correct it, obviously delirium is going to get better. If you're going to manage pain, obviously it's going to, when a person comes with severe pain, if you give a morphine trial or if you're giving some analgesics based on the pain severity, obviously the delirium is going to come down. If you see that the person has a urinary retention, you are inserting a nail cap, and if you are draining the urine, obviously the person is going to get calm. And if you are doing PRE, you are finding out that it is a lower rectum or if it is a balloony rectum, you're going to give an enema, and if he passes stools, delirium is going to go. So it is very, very important that you correct the correctables first. And then for the pharmacological measures, we go with antipsychotics like haloperidol, as I said, is first line drug for delirium management. And then we have benzodiazepines like lorazepam, midazolam, and also sedation. Sometimes when the person is very delirious, you are not able to manage the patient and the person is in end of life, obviously you can go for a terminal sedation at end of life phase. So moving into the general measures, first you have to stop the offending cause. You find out some cause. If you find that this is the offending factor for delirium in so and so patient, then you need to stop the offending cause. Or if you find out that morphine is the drug which has precipitated delirium, then obviously you need to switch to some other opioids or try something else to manage, his pain. So it is very, very important that you stop the offending treatment for cause. Correct the metabolic abnormalities. As I said, the patients can present with hypercalcemia, hyponatremia, hyperkalemia, whatever it is. If you correct the metabolic abnormalities, the person comes with sodium of 140, correct sodium levels, obviously when it becomes normal the patient is going to be okay. So correct the metabolic abnormalities when and where needed, and you need to have a structured setting for people who have delirium. There should be a quiet room. You should have a low voltage light. Like most of the ICUs have very bright lights and it's being switched on for 24/7. Sometimes that can also lead to delirium. And you need to fit a calendar, a clock for him or her to get oriented. Like, today you fit a clock, you keep a calendar, and next day you just ask him the time. Might be you can see whether his eyes are going to the clock to see and tell you that this is the time. If you don't keep a clock, if you don't keep a calendar, just go and ask like what is the time today. Obviously he might not be able to tell it right because already he is in delirium. So you need to make some changes in your clinical setting to treat delirium in a proper way. These are some things which are not pharmacological measures, which are very easier to do and can be employed at any setting. So you have to encourage the visit by friends and relatives. When you see a patient who is very, 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 hyperactive and has a hyperactive delirium, many times after managing also, we have the thought that this patient had a hyperactive delirium and we will just ask them, no, nobody comes to the OP, nobody comes to the inpatient unit. He has to be alone. No, don't do that. If he is recovering, if he is getting better, then you have to encourage the visits by friends and relatives. I know it is COVID time, you can't allow everyone, but at least the people who are very familiar, even at end of life, if the patient has delirium and he is a little bit comfortable after your management, you can allow relatives to come and see him for a few minutes, and you have to use less physical restraints, and you have to encourage early mobilization if it is not a terminal delirium. And care of bladder, bowel, and pressure sores, very, very, very important with nursing aspect as well as with medical aspect, because bladder, as I said, urinary retention can happen, and if you don't care it well, there will be more infections happening. Pressure sores, if you're not going to manage it properly, you're not going to give the advice clearly that so and so patient is bedridden, you have to turn the patient like 2 hours once, you need to keep him in an air bed. All these things are little bit things, but we don't do it properly. That is the only reason why they end up with a very big pressure sore, which leads to even more infection. And when you see after 2 weeks, you would have seen the patient 3 weeks ago, and when you go back, you would see a big sacral pressure sore with the infection, and everything is gone. So these are some things which need to be kept in mind. Management of pain, it is very, very, very important, which are very simple, and you need to keep a track on. If you are giving tab morphine every fourth hour for the patient, just ask him like what is his pain score as of now. If you had given 6 a.m. in the morning, and then again you are going to give the next due at 10 a.m., you need to ask him how his pain was the pain controlled? Is it okay? All these things you need to do it properly. I think you might have had a very big session on the management of pain, but I was just highlighting on these aspects. And you need to address the fear and anxiety. You can see that most of the patients and families, patients who have delirium, they will be very, very anxious, restless. The family members are also very, very anxious because they don't know what's happening. So you have to address that by proper communication. So these are simple general measures which can be done at any setting. And you need to maintain the adequate hydration, except for people in end of life care, obviously. We might not be able to maintain the actual hydration for like how we do for a normal patient. So some instances, if the family says that they want hydration, then you can go for a subcutaneous hydration when a person is in end of life. And you need to ensure family support throughout the process. I can still remember during my initial days, when I joined Pallium, and when I was, I don't know the language. I had a language barrier because I come from a different state. And when I joined Pallium India, it was very difficult for me to manage a person who was 35 years old, has a very ampullary carcinoma, who was in terminal delirium. It was a very bad delirium that I had seen in my all years of practice, because at around 1 a.m. in the night, he started shouting, he started yelling at me, he started speaking few bad words. We need to understand that at that moment, we shouldn't be getting angry on the patient. Obviously, we might go into that kind of feeling like why he is speaking so and so, but he was delirious because of pain, because his respiratory rate was falling, and we were not able to give the actual dose of pain medications that have to go. We reduced it by 30%, and at around 1 a.m. he got severe pain and he became very, very, very delirious. And then to settle him, it took around 4 hours for me to give him one shot of injection haloperidol, because he just removed all his IV cannula. He just threw it in front of me. He said he is going to call the police. At around 3 a.m. at night, he said, no, I'm going to call the police and say, you have done something to me. I'm going to report you to the police. So the team members, actually, I would say, the team has to be very, very understandable. You need to tell your team that this is how it presents. Okay, I am there for you. Don't worry. We will be able to handle it so well. So at that point, what I did was I had a team with me, my nursing team, who was very, very helpful, who said, ma'am, it's not at all a problem, because I did not have a proper language at that point before 3 years. But they said, ma'am, it's not at all a problem. We will keep quiet. We'll wait for him to settle, because we were not able to like go next to him, give a sub-Q dose of injection haloperidol or an IV dose, because he has already plucked everything and threw it away. So it took 3 hours, and then we spoke to him again and again, and then he said, okay, he allowed us to give that injection at around morning 5 o'clock. It was happening from 1 a.m. to 5 a.m. And then to give a single shot of haloperidol, it took so much of patience for the entire caring team as well as for him to say, okay. And then we gave haloperidol. He totally settled and slept well. And then we increased the dose of, the pain medications because he was going into a terminal stage. And at terminal stage, obviously, we don't look into the respiratory rate and all that. So we had a clinical discussion, and then we decided that no, this patient is going to be dying in a few days. So we need to keep him comfortable, and we don't need to reduce the dose of medication, let it go that way. So this is one of the experience that I had, which I wanted to share with all of you. So for the pharmacological measures as antipsychotics, haloperidol is the drug of choice. It's always the drug of choice. Many times, many doctors give benzodiazepines. No. Antipsychotics and haloperidol is the drug of choice for pharmacological management of delirium. It can be given per oral, it can be given as IV, it can be given as sub-Q. The maximum dose of injection, haloperidol in a day is 20 milligrams in 24 hours. So you can go up to 20 milligrams in 24 hours, and you need to watch for extrapyramidal symptoms. And we have other drugs, as I said, if the person has, allergy to haloperidol, or the person has some, extrapyramidal symptoms reported because of haloperidol, then you can go for either risperidone, olanzapine, or quetiapine. But for all practical purpose, for all clinical, usage, I would say haloperidol is the drug of choice, and we have used it at the maximum at our setting. So most probably, since if the patient is very, very delirious, severe delirium, then we can give 3 milligrams to 5 milligrams at one shot. Otherwise, what we use is like we give 1.5 milligrams as injection. And if you see a patient via your home care, if you're seeing and you want to prescribe, haloperidol, you can talk to the doctor, say that so and so patient has delirium, and then you can give haloperidol in hand. You have to advise them that you need to give such amount of the dose. Usually in India, we get it at around 5 milligrams dose, 1.5 milligrams dose, strength, all this is available. You can just say that very clearly that you need to give it at this time. Usually we give it at around at night. We usually give it at around 8 p.m. or 9 p.m. and one dose, and then you just wait and see whether delirium is getting controlled. So that is how we do. And with respect to benzodiazepines in hyperactive delirium, especially benzodiazepines are primarily used as drugs for alcohol withdrawal delirium. So otherwise, for all purposes, we only give antipsychotics, haloperidol. Otherwise, you have to give midazolam or lorazepam for a patient who has an alcohol withdrawal delirium. And this is something which is an add-on drug to antipsychotics. Like, for example, you're giving haloperidol, you see that the person is, you're repeating haloperidol. If you want him to be a little more, resting and all that, you can give midazolam as IV or sub-Q, which is usually given at doses of 1 to 2 milligrams as IV or sub-Q, and also lorazepam. If you are seeing a patient in home care, then you can prescribe lorazepam, which is usually given sublingually. The maximum dose is, 1 milligrams. You can give 1 milligram dose sublingual, wait and see whether everything is settling, and then again, you can repeat if needed after some time. So the conclusions are you should always collect the correctables first. That is very, very, very important. Go for non-pharmacological measurements and managements as far as possible. As I said, little things may change. A multidisciplinary approach may be needed. So you need to keep that in mind. Always communicate and take the caregivers along. You need to make them understand this whole process and be with them and comfort them whenever they are going through a difficult situation, and identify hypoactive delirium and treat. So we will go with this clinical scenario now. So I'll be finishing my theory session, and for 5 minutes, I think we can discuss this clinical scenario, and then we can go with the case presentation. So this is the scenario that we had discussed initially. So I had told that at the end of the session, we will have a detailed discussion of this. So here we have a 70-year-old gentleman with paraplegia who is brought to the casualty with complaints of altered behavior noticed by family members for the past 3 days. He talks incoherently and appears confused. His oral intake for the past 1 week is low. He is receiving analgesics for pain management. He is on indwelling catheter. I have highlighted the important points. I want you to say what might be the causes and precipitating factors in this patient. I want you all to unmute and answer. Otherwise, you can put it in the chat. What are the things that come to your mind with respect to the causative and the precipitating factors in this patient? Yes, very good. Sarah says constipation. Yeah, very good. Read the scenario very clearly and I think you will be able to find the causes. Yes. So there's a term a line which says he's receiving analgesics for pain management. So he might be in uncontrolled pain. Yeah. Yes. Possible infection. Because why do you say possible infection? What might be the reason? What do you think might be the reason? Yes. Very good. So possible infection because of UTI. You have not checked your GRBS. So can be a hypoglycemia that's stating. Yes, there's an indwelling catheter, so that can be a reason. Some chances for urinary retention or something like that. Yes, bowel and bladder disturbances, electrolyte imbalance. Very, very good, very good. Very nice to see all these comments. Blocked catheter. Okay, fine. Yeah. Yes. So these are some of the important causes and precipitating factors in this patient. So what are things will you assess as a nurse? So you are seeing this patient in your OPD. So how will you assess this patient? What are the important things that you will keep in mind while assessing this 70-year-old gentleman? Anyone? Or just unmute and answer, or else you can, yeah, pain medication regime. Okay. Catheter care. Okay. Rectal examination. Very good. So you will do a rectal examination and see whether he had, because he has constipation for 4 days. So even before the doctor comes, you can assess so very well. You can take a pain history. You can, like, if the person is very delirious now, so you can talk to the caregivers. You can ask about the medications he was on, whether they were giving it properly. Was there any rescue doses he has taken? For example, if he was on tramadol or if he was on morphine, you can ask, like, whether he had taken any rescue doses. For example, they say he takes 3 to 4 rescue doses in a day and he says he is in pain. Obviously, it might be a uncontrolled pain that is leading to delirium. So yes, you can ask about yes, you will do vital signs. Yeah, you will check for the pulse, BP and all that. The rectal examination you will do. Okay. Yes, you will get a history from the family. Yes, very, very good. Someone said you will do MMSC. That's really great. Very good. You can assess this very detailed, and then when the doctor comes, you can just say, these are the causes that I have found out because so and so patient has come with delirium. I can see that this person is delirious. I see this person has uncontrolled pain. I see this person had constipation, but right now I have relieved this constipation. I have given the enema. The management is done from my end. The other thing is like I had checked whether his catheter had any infection, signs of infection. I have sent for a urine routine, or you can ask him, should I send for a urine routine to see whether there is a chance, because there's a chance for infection. That also you can do. You would have assessed the urine output. You could have asked, like, the family members how the urine output has been there in the past few days. So all these things, as a nurse, I think you will be able to do it really, really well. Do you all agree? So yes, so that is the end of my presentation. I feel very happy that you all had mentioned many points in the chat. You were very interactive. So we will move with the case presentation for today, as it is already gonna be 4. And then after that, we take few questions.
Thank you, ma'am, for the presentation. Anita? So over to you.
Yes, ma'am. Hi, everyone. My name is Anita, in radiotherapy department in CEMC Hospital, Ludhiana, Punjab. Today my case presentation: gastrointestinal symptom, nausea, constipation. My patient, 78 with GBM.
Anita, your
हाँ जी,
voice
ma'am.
is breaking.
70-year-old male patient with multiform presenting a complaint for plus 1.5 month, associated with confusion, irritability, short-term memory loss, nausea and vomiting, constipation, pain, disturbed sleeping pattern, decrease oral intake because of constipation. History of illness: 70-year-old male patient diagnosed with glioblastoma, multiform grade 4, craniotomy and decompression of frontal lobe, tumor, right frontal lobotomy, presented with radiotherapy OD for further EBRT for concurrent chemo radiotherapy and patient complaint dizziness, nausea, vomiting, and constipation.
Anita, just a moment, please.
What about others?
Others, are you able to hear it clearly, or is it breaking? It's breaking. Okay.
Anita, ma'am?
Ma'am, network note.
Okay. Please
The
try once again.
investigation revealed. हाँ जी मैम.
Could you please try once again, and then if it is still have voice breaking, we can stop. You can continue.
70-year-old male illness. 70-year-old male patient with diagnosed glioblastoma, multiform grade 4, craniotomy and decompression of right frontal lobe, tumor, right frontal lobectomy, presented to radiotherapy OPT for further management EBRT to brain. He was planned for concurrent chemo, radiation, and weekly temozolomide 120 mg OD. During the course of treatment, patient complained drowsiness, nausea, vomiting, and constipation. Blood investigation revealed hyponatremia. He was started on tab dexamethasone OD and regular sodium supplementary in addition to supportive care. Examination. On examination, the patient was conscious and oriented, temperature 98 Fahrenheit, pulse 80 per minute, respiration 22 per minute, weight 62.8 kg, height 156 centimeter, symptom with normal limit. Treatment and significant investigation. Routine investigation done. HB 12.30, 12.3, TLC 10,400, platelet 2.5 lakh, creatinine 0.9 mg, serum sodium 137 mg, MRI brain, large irregular heterogeneous lesion in right frontal lobe. Medication. Tab temozolomide 120 mg OD, tab dexa 4 mg OD, tab pento 40 mg BD, tab levera 500 mg OD, tab MSET 4 mg TDS, syrup crimafin 2 teaspoon HS. Next one. Psychosocial aspect. 70-year-old old man with 2 children living in rented house. He is now unable to go to Gurdwara. This makes him very sad. He communicates through cell phone. His family has taken rupees 1.5 lakh loan from private finance bank for his treatment. He is very specific nature. Main concern: nausea, vomiting, constipation. Summary: 70-year-old man diagnosed with glioblastoma multiforme grade 4, craniotomy and decompression of right frontal lobe, tumor right frontal lobectomy. Discussion point to be discussed in class patient story. Do we need to provide palliative care for the patient? What are the problems faced by the patient? What all can be done for this patient? Thank you.
Okay, thank you, ma'am, for the presentation. We can move on to the discussion points. We would like to hear from you all. Now you had a wonderful session ahead. Anyway, that you all know that what is delirium and what is palliative care, what how to communicate with the patient and the family, that all you know. So now you can tell us, do we need to provide palliative care for this patient?
You can put it in the chat or you can unmute and answer. What do you think hearing to this patient story? Do we need to provide palliative care for this patient?
Okay, good. All said yes. Definitely, this patient need palliative care. And the second question is, what are the problems faced by the patient?
Financial, okay. Yes, financial, physical, psychosocial, spiritual, yes. So can you address these problems? Like when you say physical, what are the physical problems this patient has? If you can categorize and type it in the chat, then it will be a great discussion. Like you have heard the total story. Just think about what are the physical symptoms and problems this patient had. Yes, very good. Vomiting, constipation, nausea, vomiting,
Pain.
pain. Yes, very, very good. Pain. Okay. GI symptoms are there. And also, he was little irritable, right? In the history, there was a point saying that the patient was little confused and irritable. So that could be a delirium, and we have pain also. Might be pain is one reason this person has delirium, because if everybody would have read the story very clearly, then you could see in the prescription there was no medicine prescribed for pain, right? So obviously, pain might be one reason this patient would have had delirium, and also constipation. Constipation was there. So constipation would also be one reason why this patient presented with delirium. So might be a cause. Just thinking. And yeah, he is tired. Spiritually, religiously, he is unable to attend the Gurdwara, which is adding more emotional and spiritual issues to his, life. And financial, yes, have taken loan from the private bank. What all this will do, like, when spiritual component comes in, financial component comes in, it will add up to the total suffering. It will affect the patient's total suffering and the way how the total pain is perceived, right? If the patient has 10 bar 10 pain score, obviously, if this patient has a 10 bar 10 pain score, I would say yes, yes, he should have it, because he has so many issues. You can see in the history that he has so many physical, emotional, spiritual issues happening, social, financially, he is not able to repay the loan. So many things are he is having, and he will have a total suffering for sure. So, what all can be done for this patient? Pain management is very good. Analgesics for pain. Counseling, very good. Financial support, okay. So for constipation, Leela Kanti, sister, what will you do? If the patient comes to your OP, what will you do? You find that the patient has constipation, so how will you manage it? You can add a laxative, but prior to that, you will see whether you will take a detailed history of constipation. How many days constipation? When was the last satisfactory bowel passage? That is very, very important. Whenever you're taking a history, you should be very clear with this word satisfactory. Whenever you're asking, just don't ask, is your pain reduced? Ask whether he has a satisfactory pain relief, and also ask whether his last bowel habit was satisfactory. He might tell you that he passed bowels 4 days back, but that might be something which is not very satisfactory for him. So you should ask whether the last bowel habit was satisfactory, and then if you find the history points to constipation, then obviously you will do a parectal and examination, and then based on the findings, you will proceed with giving a suppository or enema as a rectal measure. And also, the patient has constipation and he is only on syrup trimafin at night. So whenever you are going to start morphine, what kind of laxative will you prefer first? Anyone? Lactulose. Will you prefer lactulose first? When you are giving morphine, the most common side effect of morphine is constipation. In the initial days, you can have nausea, vomiting, but later that subsides. But constipation, you need to treat every day. So, what will you give first along with morphine? The hand that writes morphine should write this. What is that drug? Stool softeners like, lactulose or clemaphin is something which is an adjunct. Yes, Dulcolax. What is Dulcolax? Dulcolax is bisacodyl, which is a stimulant laxative. What does morphine do? Morphine will cause the peristalsis. It will affect the peristalsis. Morphine slows the peristalsis of the bowel, which will lead to constipation. So you need to give a stimulant laxative first. It should be regular. You should give it every day with morphine, with any opioid, like whether it is a weak opioid or it is a strong opioid. You're going to prescribe tramadol or morphine. You should write a bisacodyl prescription. Many times even your doctor might miss, but you should tell the doctor, like if they are very busy and they forgot to write the prescription, you should say, doctor, see, you have written morphine, but bisacodyl is missing, no? So we need to give, and then he will remember, okay, sorry, I just forgot, let me write it. So that is very, very important. You need to keep in mind that whenever you are giving a weak or strong opioid, you need to add a stimulant laxative, that is bisacodyl. The dose that we give is 10 milligrams. 10 milligrams SHS, and then probably with proper assessment, if you feel that the dose needs to be titrated, your doctor will increase the dose. But you need to keep in mind that you should add bisacodyl. And along with that, plus or minus, you can add syrup clemaphin or syrup lactulose, stool softener. All these things can be added on. But the primary drug is bisacodyl. Clear? So what else will you do? You have to do a total assessment for this patient. When he or she comes to your OP, you should do the total assessment. You have to assess in total the physical, emotional, social, as well as the spiritual part. And then as a nurse and as a doctor, what I would say is you need to go into all these sectors like physical, emotional, social, as well as spiritual. But in terms of financial issues, if this person presents to your OP with financial issues, then you can call the social officer. You can call the social officer and say that so and so patient comes from below poverty line and presenting to us with some financial issues. So based on what your organization has in place, the policies in place, then the social officer will assess his or her own assessment, and then they will let you know regarding how this can be processed further, whether we can provide some financial support. Might be his children are not studying because he went into a serious health related suffering and the whole total family is in suffering. You find that the children are not going to school properly. Then what you can do is you can give some educational support. If your organization permits doing it, then obviously the social worker will assess and then they will proceed further. So that is very important. Yes, total care. That is very, very important. So what do you mean by total care? If the patient is very much bedridden and the patient is going to, die, the patient has, is in end of life, is in terminal delirium, just keep it in mind. This patient, the same patient who Sister Anita has presented, now goes into a near end of life stage and he gets admitted to your IP. So then total care, you need to give a total care for this patient. If he is completely bedridden, you will advise regarding skin care, you will advise regarding position change, you will advise air bed, and then you will look for the oral care, whether the oral cavity is clean, whether it is dry, or if it is moist. And then you will look for any thrush in the oral cavity. And then what you will do, you will advise accordingly. You will give some candid mouth paint, or else something that we use, right? Soda bicarb with salt in lukewarm water, and then you perform a proper oral care for this patient. Initially, you need to do it, show the family members like how you do it, and then start educating them on this. And then next, after 2 days, you see how they are doing it. And then if they do have any mistakes in that, you correct them, and then you send the patient home. Okay, so that is how we do. And also, if the patient is in a catheter, you need to do a proper catheter care, and you have to check if the patient is, going to die. He has not passed stools, then he is not able to take orally. So you're not giving bisacodyl or something like that. Then what you can do is every day 3 you can keep a suppository. You can keep a bisacodyl suppository for this patient, or a parectal examination, and then decide based on the doctor's advice to go with an enema and whatever it is, and then you manage the patient. As well as you need to provide nail care, all these little things, no? That is what which comes under total care, hair care, nail care, all these things come under total care. I think Sister Sheba will be able to add even more on that.
So Madam has covered almost all the things, but I can add one point. Because if they have a financial problems, we have a wonderful palliative care organization here, but I don't know whether you have a good palliative care facilities in your hospital or not. If you don't have a such a palliative care center in your hospital or your area, so what you can do is, if you find some financial constraints in the patients, you can connect a NGO, like nearest NGO. You can find an NGO nearby and connect with them so that they can able to help them. So here we have a lot of social officers. So we will, if they have a psychosocial issues there, nurses will be find out initially. After that, they will refer to the social officers. The rest of the assessment part, the social officers, social workers will be doing, and after that they will come to the doctor, and they have a group, and they will discuss together and make a decision plan. So that is why here happening. We have a wonderful team: doctors, nurses, psychologists, medical social workers, and sometimes volunteers. These all, so, and physiotherapists. They all come together and discuss. For our ultimate aim is to improve the quality of life of the patient and the family. So each and every point we will discuss. How can we help them? That all things we will discuss. And another point I want to add is, if as always I said, like nurses are spending more time with the patients. If you have seen these kind of patients in your settings, for example, delirium, you are the persons you have to do the proper assessment. And if you do the proper assessment, definitely you can able to identify whether there is a delirium or other problems. You have to identify the cause of delirium first, and then you have to treat the patients. You have to treat the underlying cause first. And the next important things is, if the patient start delirium, the caregivers might be thinking like this is mad. Okay, so you have to tell the caregivers about what is delirium, as madam was discussing before, because they don't know what is delirium. They might be thinking like, okay, he or she has started with madness, something happened. So you have to tell them why the patient is started delirium. Maybe it could be related to constipation or retention of bladder, sometimes electrolyte imbalance, sometimes metastatic, many problems. So these you have to identify and tell them about that, what is the proper cause of this problem, and then you have to give a good explanation and reassurance. The patient reassurance is also that you have to do. That's it. And you have to think about the non-pharmacological management first and then go to the pharmacological management. And you can think about the geriatric groups. When they come to the hospital, the environmental changes is the major problems to start delirium and the restraints. If they usually what we do is, if the patient start with delirium, we used to take, instead of identify the cause, we used to do restrain their limbs. If you restrain their limbs, what happened? Their agitations will increase. What you can do is you have to identify the cause first and treat the underlying cause. Then no need to restraints. If you treat well, no need to restrain. If you restrain, definitely their agitations will increase. Okay.
Thank you, Sister Shiva, for adding that cherry on top. So, any more questions? The most silent batch I have ever seen, I guess, who are very active on chat. But that was a great discussion because you all were messaging in the chats. I was able to see that, okay, somewhere you all are following and able to get it. If we don't have more questions, I think we can close for today's session. It was a great session with all of you. Thank you so much.
Thank you, Dr. Farhana. Wonderful session. So thank you all for your discussions, and you are contributing a lot of points and